Welcome to Revitalize Education. In this video, we continue with our series on vascular emergencies, focusing on how these patients present and some assessment considerations. If you haven't already seen the vascular emergencies overview video, make sure to check that out. Otherwise, let's jump right in. There are 5 major presenting symptoms of an aortic dissection: acute pain, focal neurological deficit, pulse deficit, heart murmur, and malperfusion or hypotension and shock. Acute onset of severe chest or back pain occurs in 80 to 90% of aortic dissection patients. Generally, this pain is described as severe, sharp, or tearing. Pain presenting in the anterior chest is more indicative of a type A dissection, whereas posterior chest or back pain is more commonly seen in type B dissections. Pain also can be described in the flank or abdominal area or the lower extremities. This can be related to progression of the dissection or to malperfusion caused by the dissection. Focal neurological deficits may be due to the expansion of the dissection into the branches of the aorta or from compression from the false lumen. Stroke or altered mental status may be seen if the dissection involves the carotid artery or compromises cerebral blood flow. Alterations in level of consciousness is more common in females than in males. Paralysis or paraplegia may be seen with spinal cord ischemia resulting from vertebral artery dissection. An interruption in the intercostal vessels may also cause paraplegia. Generally, this is more often seen in type B dissections. Horner syndrome occurs when one pupil is constricted and is due to an interruption of the sympathetic nerve supply to the eye. Due to the location of the dissection, hoarse voice may also be seen due to the compression of the left recurrent laryngeal nerve. Syncope is also a possible presentation occurring in 5 to 10% of dissection patients. This may be indicative of a cardiac tamponade or involvement of the brachiocephalic vessels. Patients who experience syncope are more likely to develop poor cerebral perfusion and stroke. Generally, syncope is found in most often type A dissections. Depending on the vessels involved, limb ischemia may be noted. Any of the limbs may be involved depending on the extent and location of the dissection. Type A dissections more commonly have upper extremity involvement, whereas type B dissections have lower extremity involvement. Pulse deficits of greater than 20 millimeters of mercury may be noted between extremities. Therefore, it's important to evaluate bilateral blood pressures to assess for discrepancies. If the aortic root is involved, the coronary arteries may be affected, resulting in ST segment changes and acute myocardial infarction. The right coronary artery is most commonly involved, leading to an inferior myocardial infarction and an increased potential for conduction abnormalities, including complete heart block. If the dissection extends proximally, it could extend into the aortic valve, leading to acute aortic regurgitation. Aortic regurgitation is characterized by a diastolic murmur with severe chest pain, wide pulse pressure, hypotension, and even heart failure. Murmur associated with acute aortic regurgitation is more commonly found in the younger patient population suffering from aortic dissections. The dissection may also extend into the pericardial sac, leading to a cardiac tamponade. This is a common cause of syncope in aortic dissection patients. Cardiac tamponade can lead to sudden death and is more commonly found in females. Cardiac tamponade generally presents with JVD, narrow pulse pressure, and muffled heart tones. Cardiac tamponade in the setting of hemodynamic compromise or peri-arrest is an emergency and needs to be drained with a pericardiocentesis. Depending on which vessels of the abdominal aorta are involved, the patient may present with a variety of GU or GI symptoms. The patient may experience nausea, vomiting, or abdominal pain if the celiac or mesenteric arteries are involved. They could also develop renal failure if the dissection extends into the renal arteries, resulting into increased creatinine and decreased urine output. While aortic dissections can present with a variety of symptoms, research has found that 96% of dissections could be identified with the following clinical triad, including acute abrupt pain, discrepancy in blood pressure measurements in the upper extremities of greater than 20 millimeters of mercury, and a widening of the mediastinum visible on chest X-ray. It's worth noting that the absence of these three symptoms does not exclude aortic dissection, but it does increase the likelihood of a misdiagnosis. Since we've discussed the clinical presentation of aortic dissections, it's worth highlighting the areas that we need to monitor and assess while caring for these patients. Our assessments should reflect the different aortic vessels that may be involved. For example, monitoring the patient's EKG for ST changes would allow us to see if the coronary arteries are involved in the dissection. Especially in a type A dissection, even if the patient doesn't initially exhibit ST changes, it's critical that we continue to monitor the EKG in case the dissection extends into the coronary arteries. And remember that the right coronary artery is more commonly involved, so pay extra attention to leads 2, 3, and AVF, which could indicate an inferior MI. These patients are also at a greater risk for a posterior MI. As we discussed earlier, the presence of a diastolic murmur may indicate aortic valve involvement. Therefore, it's essential to auscultate the right sternal border for a murmur indicating aortic regurgitation. It's also extremely important to assess the patient's neurological status and evaluate for stroke-like symptoms. Completing repeat stroke assessments allows us to evaluate if the carotid arteries are impacted by the dissection. Bilateral upper extremity blood pressures is one of the easiest and quickest methods to evaluate for a dissection. Evaluating bilateral blood pressures and finding pulse discrepancies of greater than 20 millimeters of mercury is a strong indicator of a dissection. It's imperative to perform bilateral blood pressures on every patient who presents with an altered mental status or stroke-like symptoms or myocardial infarction symptoms. This is especially important to evaluate prior to administering any blood-thinning agents, such as TPA or aspirin. The arm with the higher blood pressure should be used to titrate vasoactive medications or to guide fluid resuscitation. Next, we need to monitor and be prepared for nausea and vomiting, especially when the dissection includes the abdominal aorta. Nausea and vomiting, especially in the setting of altered mental status, may limit the patient's ability to protect their own airway, and intubation may be necessary to mitigate any aspiration risk. We also need to closely monitor the patient's urine output. Due to the risk of catheter-associated urinary tract infections, some institutions may shy away from Foley's to monitor urine output, but it's critical to closely monitor urine output to ensure the renal arteries are not affected by the dissection. Trending the patient's creatinine level is also helpful in monitoring kidney function, but monitoring urine output tends to be an easier and quicker method to monitor kidney function. The last bullet point highlights the need to assess the extremities, especially the lower extremities. If the patient's dissection extends down to the bifurcation of the iliac arteries, one or both lower extremities may have decreased perfusion. Using a Doppler may be necessary if perfusion is compromised. Assessing for equal and adequate pedal pulses is extremely important to assess for dissection progression. Now that we've reviewed the clinical symptoms and assessment considerations of an aortic dissection, make sure to check out our next video and learn about how aortic dissections are diagnosed.